Assalamu alaikum everyone. I'm Tariq and I'm going to be doing some neuroanatomy questions today. This is going to be a little bit unhinged because I had a bit too much caffeine earlier, but that's okay. We can move on. All right. So basically what I've done is I've gone through the past 3 batches for their previous questions, and so we're going to be going through those, and then we're going to be doing a couple of book questions. There's a couple of things I want to emphasize. So because neuro is mostly anatomy, I've tried to get quite a good number of questions, because one of the things that makes neuro so much different to, for example, previous blocks, is that you get a lot of questions that are very long, and there's so many of them that it gets like really, really exhausting. So for me personally, it does kind of help that we did it on the 3rd day of Ramadan and at 8 a.m. So everyone was exhausted. But you get to about question 70-ish, and you are completely worn out and you can't even read the question in front of you at that point. And so one thing I want to try and emulate if I can is that feeling of a very long session of constantly having to go question after question after question. But beyond that, we're just going to try and keep things chill, try and keep things chaotic, and hopefully have a bit of fun, but we'll see, inshallah. So, first off, we have a bit of an OSCE question. We have the sensory examination of the patient. We have loss of pain and temperature in the left lower limb. Okay, and which of the label tracks provided transmits pain and temperature? That's question 1. Question 2 is mentioned 2 arteries that supply this structure. All right, just give you guys a second to have a think. All right, so for starters, we have the left lower limb. So that means that for the sensation, since it's pain and temperature, we're going to be looking at the spinothalamic tract, and because it's pain and temperature, specifically the contralateral spinothalamic tract. All right, and so in this case, okay, we'll be looking at the right-sided spinothalamic tract, so that's going to narrow down the answer to I, or specifically the lateral spinothalamic tract. So the answer here in this case would be I for question A, I guess. And then B, 2 arteries that supply the structure. It's just a very, very straightforward recall question. You have 3, in quotations, sort of arteries that supply the spinal tract. You have 1 anterior artery and then 2 posterior arteries. And so that's going to be your answer for this question, the anterior spinal artery and the posterior spinal arteries. And so again, just to recap very, very quickly, these are our spinal cord nuclei. You have the spinocerebellar tracts. These are going to go to the cerebellum, and they're going to have unconscious proprioception. The posterior column handles fine touch and conscious proprioception. And then you have the spinothalamic, like we said, is going to handle pain and temperature. And then you have the motor nuclei, which handle movement, as is obvious. Okay, so then the next question. 52-year-old woman comes to the physician for a follow-up. 6 months ago, she had a right upper lobectomy and then adjuvant chemotherapy for locally advanced adenocarcinoma of the lung. Since her last visit, her speech has changed. She's now awkward with her sentences, and she breaks down words into separate syllables. On physical exam, her movements are uncoordinated, and she leans to the right side when she stood up. A CT scan of the brain shows a tumor in the right cerebellar hemisphere, so they've given us the diagnosis right away. Which of the following is an additional finding that is most likely to be present on physical exam? The answer to that is going to be... Okay, so you're not going to show an upbeat nystagmus, because since it's in the hemisphere, what you'd most expect is some sort of limb ataxia. Okay, so right away you can eliminate almost all of the options here, such as truncal-ataxia, resting tremor, and the positive Romberg test, because the resting tremor, because it's not related to the cerebellum, and the Romberg and ataxia, because these are more related to the trunk. And here we're looking for a limb issue or a limb tremor, and that's why you're going to get your abnormal finger to nose test, which indicates dysmetria, like it says here. Okay. A man comes to the ER with a wide gait, and he's ataxic and has slurred speech. His history reveals that he has been admitted into rehab for alcohol addiction 3 times in the past 5 years. He's also been arrested for drunk driving twice in the past year. His symptoms are most likely due to atrophy of which of the following? I'll just give you guys a second to think. And if you want to suggest an answer. Okay. So for this patient, we have he has a wide gait and he has ataxia. So that immediately narrows down our choices to the vermis. We know it's not going to be the frontal lobe because that would result in spastic paralysis. And we know it's not going to be muscles of the lower limb because, well, A, it's neuro, you're not really expecting questions about the muscles, and B, because that would just result in weakness of the lower limbs and wouldn't really result in ataxia. So we know it's going to be in the cerebellum, we know it's going to be in the vermis of the cerebellum. The reason that it is anterior and not posterior, making the answer C, like you said, good job, mashallah, is related to how you look at the divisions of the cerebellum. So if you look over here, what we have is we have the cerebellum, and you can see that we have the homunculus mapped out along the vermis, and you'll notice that the trunk is in the anterior portion of the cerebellum, which produces the truncal ataxia that we see in our case. And here's just an overview of the cerebellum, just to recap it very, very quickly. This is just how you can divide it functionally. So you have the cerebrocerebellum, spinocerebellum, and vestibulocerebellum. The cerebrocerebellum is going to be your lateral hemispheres. These are going to control your limbs, and it's important for visually guided movements. That's why, as we saw in the previous case, not this last one, the one before it, they had an issue of a finger to nose test, which is a visually guided movement. And as for the spinocerebellum, which is what we saw in our second case, is what you're going to have with the vermis. For this one, it's mainly concerned with the middle of the body compared to the hemispheres. So a damage to the spinocerebellum, you'd expect some sort of truncal ataxia, again, based on this homunculus that you see here. As for the vestibulocerebellum, it's literally just the floccular nodular lobe. And so this part is mainly involved in balance and reflexes, and it's going to be communicating mostly with the vestibular system and nuclei. Okay, so here's our next question. It's very straightforward. Name the structures.
Why was the previous answer not posterior? Vermis? Oh.
Sorry about that. For the previous question, why was it not posterior?
Yeah, what's the function of the posterior vermis?
Okay. So basically, as like the homunculus sort of suggests it, but just to go into a bit more detail. Okay, so I'm hoping you can see the screen here with a million tabs, but this is basically directly from the lecture. You have the main cerebellar syndromes, anterior, posterior, and then hemispheric. So if we look at the question very quickly here on this other device, we have a patient that has a wide gait, that's also ataxic, and he has slurred speech. Okay, so in this case, because they have gait ataxia, and anterior vermis syndrome is most commonly associated with drinking or alcohol abuse, that would make it more preferred to be anterior vermis syndrome. It doesn't necessarily rule out posterior vermis, which is why you'd want to look in further and then properly localize it. But posterior vermis syndrome would present more with tumors, whereas anterior vermis would present more with alcohol. And the difference in ataxias being just truncal versus gait and truncal as well. And yeah.
Okay, yeah, that makes sense. Thank you.
Okay. All right. So this one's okay. Yeah, that's also a good point, because again, mostly you'd expect medulloblastomas and tumors like that to be more present in children as well, which is why you'd expect posterior vermis syndrome to be more prominent in children. So for this one, naming the structures, just give you guys a moment to have a quick look. All right. So for number one, it's kind of hard to see, to be fair, with this image, but does anyone want to take a guess?
Middle cerebral.
Okay. So this one here is actually the basal artery. The middle cerebral for this level is going to be these two larger arteries that are here at the side.
Okay.
Cranial nerve 3 is, I don't know, it's not going to be at this level. So the thing about cranial nerve 3 is you'd mostly expect to see it with the midbrain. And the easiest way to identify the midbrain is, of course, by the substantia nigra, which you can't really see here. So for this particular image, number 1 is going to be the basilar artery. Number 2, does anyone want to take a guess? And number 3, since they're kind of linked. Okay. So number 2 is going to be the pons. The main identifier is that you can't see the olive, which you'd expect to see in the medulla, and you also can't see the substantia nigra, which you'd expect to see in the midbrain. That would make this one the pons. As for number 3, it is the vestibulocochlear nerve. Again, because we are at the level of the pons and it is heading out laterally. And if you pay very, very close attention here, you can kind of see it heading towards the ear. To make it the. As for number 4, the obvious answer would be the cerebellum, but yeah, so the obvious answer is the cerebellum. If you want to be a bit more specific, you could technically say the cerebellar hemisphere. The cerebellum, I think, would be correct here as well. Okay.
What was number 3, sorry?
Number 3 is the vestibulocochlear nerve.
Okay, all right.
Okay. So, which area does the optic fibers pass through? 33, 35, or 37? If anyone says 42, I'm going to leave. Okay, so yeah, 37 would be the correct answer. 33 and 35 are parts of the internal capsule, which are not really related to the optic fibers at all, actually. This is a quick diagram just to review the pathway for the optic fibers. You start with the eyes, of course, and so here we have the 2 eyes. And then we have the optic nerve, which is number 2. And so here it's showing you what would happen if you had a lesion in at number 2. You'd have complete loss of sight in the left eye and preserved sight in the right eye of both sides. Okay. Then you have the optic chiasm, where you'll have crossover of the nerves, so that all of the right-sided vision and all of the right-sided vision is on the left, and then all of the left-sided vision is on the right. And so if you have a lesion at the optic chiasm, you'll have bitemporal hemianopsia. And then, as you can see, it travels to the lateral geniculate nucleus, and then it sort of fans out in these optic radiations before gathering again at the occipital lobe. Okay, and because it fans out like this, that's why you can get these quartile lesions where only 1/4 of vision is affected. Notice how there's macular sparing because the macula is supplied by both sides. And finally, just note how, again, there's macular sparing for the occipital lobe at the very end, compared to how, if you have a lesion at 4, which is as it heads, as the optic tract heads to the lateral geniculate nucleus, there's no sparing at this level. Okay? So, we have a question about left inferior hemianopsia. Which artery is damaged? That as a wink, we sort of half covered it earlier. If anyone would like to take a guess. Okay, so let's have a quick look at this diagram once more. Now, we said that the patient has a lesion of left inferior hemianopsia, okay, or hemianopia. By the way, just as a side note, the two words are interchangeable, so if you see them used, they are basically the same. Hemianopia and hemianopsia. Okay, so we have an inferior hemianopsia, which means that it is in this 6 area. Now, obviously, because he has a left inferior hemianopsia, then it's going to be on the right side, but for the sake of demonstration, we can pretend that the image is flipped. And so as you can see, it's at level 6, it's going to be all the way at the back here, in the occipital lobe, which would mean that by default, you can almost entirely eliminate anything that has to do with the middle cerebral artery, right? Now, if the option was number 5, then the middle cerebral artery or some branch of the middle cerebral artery would be correct in that instance. But because in this case, we can't, because in this case it is going to be in the occipital lobe, we can almost entirely eliminate the middle cerebral artery. So A is a good guess because you would expect it to involve the posterior cerebral artery. The reason it's not the posterior cerebral artery in this case is because if you look at, is because the posterior cerebral artery is a very large artery by comparison, all right? And so when you have a lesion that affects the PCA, what you're going to get is you're going to get this unilateral hemianopsia with macular sparing, right? Which is going to be option 7 down here, right? And the reason is that you'd expect a much larger lesion if you're affecting such a large artery, right? If we look at this question again, if, for example, one of these options had said the middle cerebral artery, you'd expect it to maybe be option 4. Like you'd expect it to have a lesion that presents as 4, for example, right? Where you're going to have a complete unilateral injury, okay? And so that's why for this case, you'd expect it to be the thalamostriate branch of the PCA. Is that clear? And I can't really show you my other screen here, so I'm kind of need to. Okay, I couldn't really find the image, so we're going to move on, but I hope it's somewhat clear why it's the branch of the PCA and not the larger artery. Does that sound good? Okay, sure. So, like we said, we're eliminating C, D, and E on accounts that they are the middle cerebral artery. Okay, and so if we look at this diagram, we know that since we have an inferior hemianopia, we're expecting it to be number 6 here, which is the inferior hemianopia. And so we know that the lesion is going to be somewhere in this area, right? Since this is all the way at the back of the brain, with this being the front and this being the back, let me just, that should be a bit more visible. Okay, so since this is the front, this is the back, number 6 is all the way in the occipital lobe, and so we already expect that it's going to be somewhere affecting the posterior cerebral artery, right? Now, that would leave us with A and B, which both affect the PCA. Okay? Now, the thing about A is because it's going for the PCA directly, right? If we have a damage to the major artery, the posterior cerebral, like the big posterior cerebral artery, you'd expect to have major damages to the brain back here. And so you wouldn't really think that it would be a small lesion such as in 6. You'd expect something a bit bigger, such as a left-sided hemianopia, right? Or such as 7, okay? Because 6 is such a small lesion, you need the branch, you need the artery that's affected to also be small. Does that make sense? And so you can't really have damage to a big artery and then get a small lesion. And as for the numbers, so for this lesion, we're expecting like number 6 here, which is the inferior hemianopia, which corresponds to like this part of the brain over here. Hopefully that's clear. Okay, so next question. If you have degeneration in the structure of the marked by this red star, what will you get? B? Okay, so this question is very straightforward, so I'm not going to spend too much time on it. But basically what we have here is we have a coronal MRI, and was this? I don't remember if this was labeled as a CT scan. Point is we have an image of the brain, and what it's showing here is it's showing an image of the hippocampus. Now, the reason you can identify this as the hippocampus is because you can see the midbrain below, right? Otherwise, you would have to say that this was the amygdala. Does that make sense? Now, there's actually a very important reason I included this question. It's because it was answered incorrectly in the previous batches, and so just be wary of stuff like that. Okay? So, the amygdala is crucial for which of the following learning pathways? Is it going to be priming, non-associative learning, skills and habits, or associative learning? Give you guys a chance to think. Okay, so D is correct. The answer is associative learning. Just to recap the function of the amygdala handles like amygdala is sort of the emotional center of the brain. It'll handle stuff like fear and all of like these negative emotions that happen, right? So, for example, if you're surprised, if you're afraid, that's going to go to the amygdala. Okay. Now, one of the key functions of the amygdala is, if you guys are familiar with the Pavlov experiment, where he rings a bell and then feeds his dog, and then eventually the dog learns to associate the bell with eating food, and so it starts to salivate anytime it hears a bell, right? And so that's an example of associative learning. So the amygdala, what it's going to do is it's going to help you build these connections, such as, oh, if I see so-and-so doctor, I start to feel afraid because I remember exams, for example. Now, does that make sense? Okay. So we have damage to the posterior limb. And which artery is going to be damaged? This one's a pretty straightforward recall question, so I'm not really going to spend too much time on it. But basically, the answer is going to be A. Right, it's the lenticular striate branch of the middle cerebral artery. If I'll just very quickly. Okay. So here we have a quick diagram that shows you the supply to the internal capsule as a whole. Now, as a rule of thumb, basically all of them are striate branches. But the way it's divided is the anterior limb is going to be from the anterior cerebral artery, the striate branches. The GNU is a combination of the anterior and the middle cerebral, whereas the posterior limb is just the middle cerebral artery. Okay, as well as the anterior choroidal artery, which is a branch directly from this. Okay, so which nucleus mediates the accommodation reflex? Yeah, so the correct answer is A, the Edinger-Westphal nucleus. Again, this is just a very basic active recall question, so there's not really much time spending too long on it. We have a patient presenting with a laterally deviated eye. He gets diplopia when he looks to the right. He also has ptosis in the left eye without meiosis. Which of the following nerves causes ptosis? So again, very quickly, in order to not spend too much time on simple recall, any case of ptosis right, is going to be mediated by the oculomotor. The facial nerve helps you close the eye, but the oculomotor is the one that will open the eyelids, and so if you have ptosis, then you have damage to the oculomotor nerve. Trigeminal is responsible for sensory input, and so it's not really related here, and also mastication. A patient with inability to close his eyes, so quite literally the reverse case of the previous question. What's the cause of the presentation? Again, the answer is going to be A, the facial nerve. So like we said, facial nerve closes the eyes. Hypoglossal nerve is related to the tongue, so not really related here. Patient presents with dysphagia, dysarthria, and deviation of the uvula to the right. He has ptosis and meiosis, and he has loss of pain and temperature sensation. Damage to which of the following structures causes uvular deviation? Okay, so yeah, the answer is D, the nucleus ambiguous. Nucleus solitarius is more related to special sensation of the tongue. Vestibulocochlear nerve is related to the ears, hearing, and balance. Hypoglossal is for the tongue, movement of the tongue, and so the nucleus ambiguous is related to motor of the uvula, which results in movement deviation. Okay, again, same case, but this time, which of the following causes loss of pain and temperature sensation? Okay, so one of the key things here that I want you to take note of is that it's the left eye. So at this level, it's going to be on the ipsilateral side. It won't quite cross over yet. And so in this case, and so that eliminates option A. It's also not going to be the spinothalamic tract because that's related. And so it's going to be relayed by the trigeminal nerve, since it's pain and temperature of the face, and since it's the ipsilateral side, the answer is going to be B for this case. Okay, parasympathetic fibers by the oculomotor nerve come from where? Okay, so just to keep things quick, a little bit quick, we have the salivatory nuclei aren't going to be related to the oculomotor nerve since that goes to the eyes. The nucleus tractus solitarius similarly isn't really going to be related to the oculomotor nerve. And so you end up with the dorsal motor and the Edinger-Westphal nucleus. The oculomotor nerve's parasympathetic fibers come from the Edinger-Westphal nucleus, just like with the previous case about the oculomotor nerve. We had the accommodation reflex. The accommodation reflex is one of the things that are handled by the Edinger-Westphal nucleus. I believe it's through parasympathetic fibers as well, and so that's the answer here. Just yeah. So the Edinger-Westphal nucleus does handle the parasympathetic fibers, which helps it participate in the accommodation reflex. Okay, so we have a patient that experiences difficulty walking downstairs and reports a double vision as well. Where do you think the lesion is most likely to be? Okay, so just a couple of hints here. Since the patient has double vision, it's definitely not going to be in the spinal cord, because if a spinal cord lesion is causing you double vision, your eyes might be in your belly, which generally isn't the case. Similarly, in the medulla, since the oculomotor nerve and the nerves related to the eye don't really travel that far down. And basically, we end up with the pons in the midbrain. And so for this case, when you walk downstairs and you have double vision, you are going to end up with a lesion in the midbrain. Yeah, midbrain is correct, basically. So here's just a let me just reshow. So this is a quick recap of the cranial nerves and their related pulses. Okay, so the olfactory nerve and the optic nerve, you won't find them in the brainstem, but olfactory is for smell, optic nerve is for sight. Then there's nerve 3, the oculomotor nerve. It has its somatic, which helps with eyelid opening and movement. And then you have the parasympathetic, which, like we said, does the accommodation reflex, and it does the pupillary reflex from the Edingo-Westphal nucleus. Then we have the trochlear nerve, which is also related to eye movement. However, this one, it controls just the superior oblique muscle. The trigeminal nerve is for general sensation of the face and for the muscle mastication. Abducens nerve is just for the lateral rectus muscle of the eye. So 3, 4, and 6 control the eye. 7 is the facial nerve. It's another big nerve, just like the trigeminal. And so it's going to hold special sensation for taste. And it's also going to be the sort of quote unquote special movements. And so that's why you're going to get your facial expression, your eyelid closing, and so on. Vestibulocochlear nerve is for balance and hearing. The glossopharyngeal nerve is for taste, but at the back of the throat. And it also handles stuff like your gag reflex and your swallowing. Okay. The vagus nerve is for taste at the back of your mouth, like so the posterior third. And also it handles parts of the swallowing, as well as functions related to the heart, which aren't really as relevant here. But you might still get asked on it, so it's best to know. Then you have cranial nerve 11, which is the accessory spinal nerve, which controls the sternocleidomastoid. And finally, cranial nerve 12 controls the tongue. Okay? Now, one other thing I want to recap very, very quickly is the brainstem, specifically the rule of fours. So the rule of fours is adapted from this paper, okay, which came out in 2005, and it's very, very crafty. If you guys have seen the Worlds and Beyond video about brainstem lesions, which I really, really highly recommend, it's around 15 minutes, and it will cover everything to do with, like, everything you need to know related to the brainstem in order to at least pass the exam. And so generally there are 4 rules in the rule of 4. The first one is the midline structures begin with M. The lateral structures or the side structures begin with S. There are 4 cranial nerves in the medulla, 4 in the pons, and 2 in the midbrain. Okay? The motor nuclei that are in the midline, so the midline motor nuclei, all divide into 12. Okay, so we have a cranial nerve 3, 4, 6, and 12. They're all going to be midline. Now, the medial structures, okay, so the 4 M's that we mentioned earlier, that's going to be our motor pathway, the medial lemniscus, the medial longitudinal fasciculus, and the motor nucleus. All right. Then there's the 4 lateral structures, which is the side structures, so they begin with S, spinocerebellar pathway, spinothalamic pathway, the sensory nucleus of the 5th cranial nerve, and the sympathetic pathway. Okay? And so here's a diagram that will show you these are your medial structures, and these are the lateral structures. Okay? And so the 4 cranial nerves in the medulla are 9, 10, 11, 12. And so in order, 1, 2 are inside the cerebrum, 3, 4 are inside the midbrain, and then the pons are the next 4, so 5, 6, 7, 8 are all in the pons. The medulla is 9, 10, 11, 12. Okay? And then this paper also talks a bit about syndromes, but I'm not really going to go into too much detail. If we need to, we can do that a little bit later. But for now, let's go back. Okay. So I'm assuming you guys can see my slides now. If you can't, let me know. So a baby had absent neural crest cells. What cells are going to be spared when the baby is born? This one's an embryo question. Yeah, so the answer is actually C. So if we look at what the neural crest cells produce, it's responsible for a lot of the surrounding, like the cells that surround the brain that aren't the neurons. The neurons, all of them, predominantly come from the neural tube. Okay? So we have a newborn that has dilated lateral ventricles, and it has herniation of the cerebellum through the foramen magnum. What's the name of this condition? B? Yes, it's going to be Arnold-Chiari, which is the herniation of structures in the brain through the foramen magnum. Okay? A cerebral aqueduct stenosis would have dilated lateral ventricles, but it wouldn't quite show herniation like this. Fetal alcohol syndrome presents basically completely differently. And as for Dandy-Walker malformation, it is the failure of the 4th ventricle to close, which produces a Blake's pouch. Okay? And so you're going to get a bunch of abnormalities like hydrocephalus and ataxic gait. Okay? And hopefully that's all clear. The following glial cells are responsible for the innate immunity in the CNS. Is it astrocytes, macrophages, Schwann cells, microglia, or oligodendrocytes? Yep, it is D, microglia. I'm not sure why they decided to italicize microglia here, but hey, I mean, stuff like that do also happen in the exam, so make sure to pay attention to them. If they happen, they can give you little hints here and there. Astrocytes are homeostatic cells that are within the CNS. Macrophages don't really exist in the CNS. Schwann cells are myelinating cells, but they exist for peripheral nerves. And oligodendrocytes are similar to Schwann cells, but they myelinate nerves in the central nervous system. One of the main things to highlight is that Schwann cells, each cell will myelinate one neuron, compared to oligodendrocytes, where one cell is going to myelinate multiple neurons. Okay? So we have a patient that presents with dysphagia, dysarthria, and deviation of the uvula. Oh, it's this case again. Ptosis and meiosis, and loss of pain and temperature. which tract is going to cause Horner syndrome? Is it corticospinal, spinothalamic, tectospinal, or hypothalamic? Okay. So, the corticospinal tract is related to motor function, so we can basically completely eliminate it. The spinothalamic is, like we said before, it's more related to pain and temperature. The tectospinal is, if I recall correctly, from the red nucleus, and it's also related to motor. And so, sort of by elimination, hypothalamic becomes the answer. This is just a quick overview of Horner syndrome. And so that's why, and so if you look here, we have our first order syndromes where it's going to be from the lateral hypothalamus, the brainstem, the spinal cord, and the superior cervical ganglion. Okay, and that's why if you look from the lateral hypothalamus, it sort of hints that the tract related to it is going to be the hypothalamic tract. Okay, and you're going to present with anhidrosis, meiosis, and ptosis, all of which are signs of sympathetic overactivation. Parasympathetic overactivation. Okay. So, which of the following presents with anterior cord syndrome? This question's relatively straightforward, but anterior cord syndrome is going to be an injury to the anterior 2/3 of the spinal cord. And so you're going to have loss of the nerves at the level of the lesion, which leads to flaccid paralysis at the level of the lesion, and then spastic paralysis below. And so from that sort of, by elimination, the answer is going to be D. 14-year-old woman presents to the ER after getting shot in the back during a robbery. On imaging, it was revealed that she suffered from a hemisection of the spinal cord. Which of the following findings would be noted below the level of the lesion? So this question is sort of a which tract is going to go where? But basically the answer is going to be D because, yeah, so the answer is going to be D for this one because vibration crosses over. Why not C? Okay, let me just... Okay, I can't really show you my other screen, which is a bit of a bummer here in this case. Okay, so if we look here at this diagram of the spinal tract, you can see here that we have the different columns that are being shown. Now, the key thing is that the spinothalamic tracts are going to cross at the level at the level of the spinal cord before going up, whilst the dorsal column is going to go all the way up and then cross over, right? I believe there's a diagram of that happening. Yeah, so here it's showing you the dorsal column going all the way up. And how it goes up to the pons and then crosses over as the medial lemniscus compared to the spinothalamic. Okay. And so if you look here, just steal the transcription shamelessly. But the key thing is that we are going to get loss of ipsilateral, fine touch, vibration, and conscious proprioception, whereas we are going to get loss of contralateral, pain, temperature, crude touch, and pressure. Okay. And so in this case, you're going to get loss of vibration. Now, someone asked why the answer isn't loss of contralateral loss of crude touch, and that's quite plainly just a very good question. There's no. I'm going to either assume that this question was appealed, if I'm going to be honest, or some sort of mistake happened with collection, because realistically it should be loss of vibration. Everything else is handled by the spinothalamic tract, which should be contralateral. Okay. All right, so we have a patient asked to draw a clock. He drew all the numbers on the right side, and he drew only the right side of the face. Which of the following causes this presentation? Okay, so yeah, the answer is A, damage to the temporal lobe. This case is a case of hemi-neglect. And so what you'd expect is damage to the non-dominant side at the temporal lobe, okay? So similar to how you have Gerstmann syndrome, or Gerstmann syndrome, where you have damage, where you have Wernicke's aphasia when it's on the dominant side. This is the non-dominant side, and so you get hemi-neglect. Okay, so this is a very, very good question. Isn't it parietal? Now, the thing is, when you look at where Wernicke's is, it's sort of on the edge between temporal and parietal. And so some resources will say that it's temporal and others will say it's parietal. From what I found, hemi-neglect is more associated with lesions of the temporal lobe. Okay. Although ideally the aphasia would be like, let me just. Okay. So if you look here, Wernicke's area is sort of at the cross section between the areas of the temporal and the parietal lobe. I don't know why the text is so awful, but we move on. And so on the dominant side, it produces Gertzmann. On the non-dominant side, produces hem neglect. But okay. So someone's saying that in the slides, hem neglect syndrome is parietal, which is also fair. Okay. Yeah, okay. So I hear it saying in the slides, contralateral neglect, which is what you don't recognize, is on the parietal side. I did have something here. You have the anyhow. So yeah, if it shows up, okay, I think just for the sake of the slides, keep it as damage to parietal lobe. Okay, does that sound good? Thank you, by the way, for pointing that out. All right. Okay. Degeneration of the neurons in the area pointed at causes which of these four diseases: Huntington's, Alzheimer's, Parkinson's, or Horner's? So basically the area pointed at here is the substantia nigra. And so degeneration of neurons in the substantia nigra leads to Parkinson's disease. Okay. The Chow-Robin space between perforating arteries and which structure? I'll just give you guys a second to okay. Thank you for letting me know. Okay, so here's the previous question again. When you have degeneration of neurons in the substantia nigra, the resulting syndrome is going to be Parkinson's. All right. Next question. Virchow-Robin space is between the perforating arteries and which of these structures? The arachnoid mater, pia mater, dura mater, or subarachnoid space? Here's a quick hint. By default, it can't be the subarachnoid space since that's a space and not a structure. Just give you guys a second. Okay, so the key here is knowing what a Virchow-Robin space is. And what if I'm able to? So here, like here on Radiopedia, a Virchow-Robin space is a perivascular space. And so they're fluid-filled spaces around the arterioles. And basically they surround any perforating vessels that you'll see. Here's a bunch of cases that you can look at where it will show you Virchow-Robin spaces around the vessels. Now the key thing here is that these will happen between the vessels and whatever's surrounding the vessels, right? And because they're in small arterioles and capillaries and venules that are inside the brain, the structure that's going to be around it, if I put this over, the structure that's going to be around it is going to be the pia mater, okay? The dura mater is the mater that's adhered to the inside of the skull, and then you have the arachnoid mater, and then the pia mater is the one that's stuck to the brain, and it separates the blood vessel from the brain. And so if you have a perivascular space, if you have fluids that are around the vessels, they are going to be between the vessels and the pia mater. Okay? So the rhombic lips give rise to which of the following structures? Yeah, so the answer is C. Just okay, so very quickly, just as you can see here in the slide, it's the development of the cerebellum happens on the rhombic lips from the roof plate of the metencephalon. Okay, so that's just to quickly recap that. Now, we have a 5-year-old patient that presents to the ER with complete loss of sensation of the right side of the body. A few days later, they present with freezing pain on the same side. Which of the following structures are going to be damaged? Okay, so In this case, since we have complete loss of sensation on the right side of the body, we already know that it's most probably going to be on the left side. The lesion is going to be on the left side most likely. And so by that we can rule out the right thalamus and the right pons, which leaves us with the midbrain, the internal capsule, and the thalamus. Now the key thing here is the freezing pain that happens afterwards, okay? Which from that we can deduce that it's going to be the thalamus. Damage to the internal capsule, you'd expect either some sort of motor deficit as well, or just the complete loss on one side. And the midbrain would most likely present with some sort of cranial nerve deficit along with the sensory deficit. And so the answer is the left thalamus. 20-year-old has an inherited A 20-year-old has an inherited progressive neural degeneration of the brain. This results in twitching movements of the head, grimacing movements in the face and tongue, as well as gesticulating movements in the upper limbs and jerking of the lower limbs. The neurons in which of the following parts are degenerated in this case? I'll give you guys a moment to think about it. Okay, so for this case, we're having a progressive neural degenerative disorder with a lot of jerky movements in the upper and lower limbs and twitching movements of the face. This means that most likely we're dealing with a case of Huntington's chorea. Okay, now if you're familiar with how Huntington's chorea happens, it happens because of a degeneration of the putamen, right? Which is actually the answer to the next question, which is the exact same case, except option B has changed, okay? And so in that case, the answer is the putamen. The reason it's the caudate here is because what you'll have is you'll have widening of the lateral ventricles and damage to the surrounding structures, which are both the caudate and the putamen, okay? And so that's the answer to both of these two questions. So a 56-year-old patient presents to the ER with complete loss of motor function. He suffered from a stroke. Which of the following sites can be damaged? So, since we have loss of motor function on the right side of the body, that means we're expecting an injury on the left side of the brain, okay? And we can just take these one by one. The left thalamus, damage to the left thalamus would mean that we'd have like other symptoms along with some sort of sensory deficit or some sort of dysregulation, which is why it's not going to be the thalamus. The medial primary motor cortex is a very, very specific location to mention in the brain. And so you would only get a loss of motor function, like just to the legs. Okay? And so that leaves us with the internal capsule, which is where you're going to get a complete loss of motor function. So in that case, since we have a loss on the right side of the body, then we're expecting a loss of function on the contralateral, so the left side internal capsule. Okay, and that's why this is the answer. So we have a 60-year-old patient. She can't feel her left face. And when she's asked to point at an object with her left hand, she can't do it, but she can do it with her right hand. Based on this presentation, a lesion of which part of the brain is most likely? Is it the frontal lobe, the right parietal lobe, the right frontal and parietal lobe, the left frontal and temporal lobe, or the temporal lobe? Okay. So for this case, we have a loss of sensation on the left side, and we also have a loss of motor function on the left side, and we have preserved function on the right. Okay, so because of this, we know that there's some sort of damage to the frontal lobe, since there's a loss of motor function. And because they have a loss of sensation, we also know that there's going to be damage to the parietal lobe. Okay? And so because of that, the answer here is actually C. Okay, so the right frontal and parietal lobe. The reason it's the right side is, again, because since all of the damage is happening on the left side of the patient's face and body, the lesion is contralateral, so the right frontal and parietal lobe. And so in this case, the answer is C. Can this be hemi-neglect? Okay. So the thing is, this case isn't exactly describing hemi-neglect. Hemi-neglect is, like as we saw earlier, you have the patient is neglecting one side. Okay, so for example, they'll brush, but they'll only brush one side. But the thing is, it's not that they have some sort of motor deficit that means they can't move the left side. It's just they are not using the left side, right? They're just neglecting it, right? And that's why, for example, they'll draw only the right face of the clock. It doesn't matter if you ask them to draw it with their left hand or their right hand, they'll still only draw the left side of the clock. Does that make sense? Okay, so we have a similar case again, but this time we're asking for which artery. Okay, patient unable to feel their left face, and they're unable to move their left side. Which artery is it going to be? The left anterior cerebral, the right posterior cerebral, right anterior cerebral, right middle cerebral, or left middle cerebral? I'll just give you guys a chance to give it some thought. Okay, so yeah, the answer here is the right middle cerebral artery. The previous question does sort of spoil it, since we are talking about the frontal and parietal lobe. And the right middle cerebral artery is basically the artery that covers both, like both areas of the brain. And so, yeah, that is the answer in this case. Okay. The next case is going to be a 59-year-old alcoholic. She presents with ataxia, confusion, dysdiadochokinesia, and a tremor when performing the... Okay, previous question. The answer was the right middle cerebral artery. Okay, basically we have the patient that's unable to feel their left side, and they are unable to move their left side. And so we have some sort of damage to both the parietal and the frontal lobes. And so in this case, the damage happens to the middle cerebral artery. All right. Back to this case. A 59-year-old alcoholic. She has ataxia, confusion, and dysdiadochokinesia. And there's a tremor performing a finger to nose to finger test. Which of the following nuclei would be affected? Yeah, so the answer is actually B. And this table from Ambos basically goes into why. Here's the different tracts of the cerebellum. Okay, and by the way, like we know for sure it's cerebellum, since the presentation is ataxia, confusion, dysdiadochokinesia, and tremors, all of which would occur if the cerebellum has been affected. And this table goes into the tracts of the cerebellum that I nicked from Ambos. And as you can see here, we have the vestigial nucleus, which is from the cerebellovestibular tract. And what it does is it coordinates balance and saccadic ocular movements, right? Or stretch reflex and motor movements. Okay, which is basically, in short, it's these tests that we're doing, right? And so balance, loss of balance would result in ataxia, as well as you get loss of saccadic ocular movements and loss of finger to nose to finger test and dysdiadochokinesia, and so on. Right? Does that make sense? Hopefully. So for this case, a 50-year-old man fell down the stairs on his head. Weeks later, he complained of a headache and tingling sensation. We have a CT scan, and which of the following is the diagnosis? I'm going to be honest, you don't really need the case. Just off of the CT scan, you can tell that it's a subdural hemorrhage. We have this banana-shaped hemorrhage here inside the brain, and that's a giveaway, a hemorrhage that it's subdural. All right. Compared to an epidural hemorrhage, you're going to get a lens-shaped hemorrhage. So if I An epidural hemorrhage would look more like this. Right, you get a lens-shaped hemorrhage that's compressing. A subarachnoid hemorrhage has a more starfish shape to it, while an intraparenchymal hemorrhage, you'll actually see where the blood is accumulating. So it'll be, for example, a pool of blood over here, and that's going to be where the hemorrhage is. An extracranial hemorrhage is just outside of the brain. This one is involving, yeah, this one does involve the bridging veins. Actually, this is part of the reason why. So, like, part of the reason why is this person is old, and so eventually, like, as the brain slowly starts to atrophy, you're going to get an increased gap, and the bridging veins, you're going to get an increased gap between the different meninges, and so that's going to sort of stretch the bridging veins a little bit. And so when a person falls down on their head, that can cause rupture of these veins. Okay, this is our second case. Oh, well, it's not really the second case, but it's another case. We have a patient that suffered from a car crash, and he has the worst headache of his life. Big giveaway sentence. And he died a couple hours later. He has a CT scan before his very unfortunate demise, is shown below. What's the diagnosis? And so, yeah, this is the starfish shape I was talking about earlier of a subarachnoid hematoma. And the worst headache of his life is the big giveaway here for this case. The moment they say the patient has the worst headache of his life, then it's immediately a subarachnoid hemorrhage. Okay? Epidural was which artery? So epidural hemorrhages are going to be in the arteries that are lining the skull. Right? There's a couple, okay, but basically the most common rupture is going to be the middle meningeal artery. So if I just try to pull up a diagram. So this here shows you the middle meningeal artery, which is going to be the most common cause of epidural hematomas. Kind of dark fun fact. This is why you'll see in a lot of movies, whenever a person wants to attempt to shoot themselves, they'll put the gun to the side of their head and not to the front. The idea is to rupture the middle meningeal artery. Right? Obviously, most of them don't know this, and they're all just copying the exact same trick from every other movie. But hey, now you have a fun fact about that. I mean, it's not really fun, is it? But you know, moving on. A patient with communicating hydrocephalus. CT scan reveals marked enlargement of the lateral and third ventricles, and the patient has a small ventricle. Right? Which of the following is going to be obstructed in this case? So a bit of a small hint, right? This is also the most common place of obstruction. But basically, yeah, it's the aqueduct of Sylvius, like you guys pointed out. The foramen of Monro is going to be the one that separates the lateral and the third ventricles. Okay, And so if you have an obstruction, what do you think you're going to present in that case? Like if anyone wants to take a quick guess.
Sorry, what was the question?
If you have an obstruction of the foramen of Monro, how would the CT scan look like compared to the one that we have?
Enlarged lateral ventricles.
Yeah. So it's going to be enlarged lateral ventricles and a small third ventricle because the CSF isn't flowing from the lateral to the third ventricles. Okay. A foramen of Luschka would present with a large fourth ventricle, and an obstruction of the third ventricle is going to be very sad. Okay. Which of the following is the embryonic origin of the cerebellum? Is it the basilar myelencephalon, the ulnar myelencephalon? Okay, so I'm going to sort of give you guys the answer, mainly because this isn't really covered within the slides, but since this question has been asked previously, there's a chance it might come back again. But basically, if you look here at this diagram, here it's going to show you here it shows you the two sides. This is the alar plate, which is basically the one on top, and then there's the basal plate, which is the one that's more on the inside and then towards the front. Okay. And so another word for the alar plate is going to be the roof plate. And so, as you guys might remember from the lectures, the cerebellum develops from the roof plate and the rhombic lips of the mesencephalon. Okay. So in this case, like we said, the alar metencephalon is going to be the answer because the alar plate is the one that's going to be forming the roof, and as well as the rhombic lips. It's going to form the cerebellum. All right. Hopefully that's clear. Okay. So this is the next case. We have a 14-year-old child. They showed up at a neurological clinic with progressive weakness of both lower limbs. 2 weeks ago, they had diarrhea, and their diarrhea was treated. On clinical exam, he has flaccid weakness in both lower limbs and a loss of knee-jerk reflex. What's the cause? Yeah, the answer to the previous question was the alar metencephalon. Indeed. For this case, progressive weakness of lower limbs, treated for diarrhea 2 weeks ago. On clinical exam, he has weakness of both lower limbs and loss of knee-jerk reflex. On exam, what's the most likely cause of weakness? Demyelination of peripheral nerves, demyelination of corticospinal pathways, degeneration of corticospinal pathways, degeneration of the posterior right column, or degeneration of anterior gray horn cells. Okay, so let's take these options one by one, right? Starting with the bottom one, because why not? Okay, so E is degeneration of the posterior white column. Now, the posterior white column is the dorsal column, which is related to sensory perception, so proprioception and fine touch and vibration, which isn't really relevant here because he's having motor symptoms. Okay, then we have degeneration of the corticospinal pathways, which is option D. In that case, he'd present with a sort of spastic paralysis. All right. Degeneration of anterior Greyhorn cells is also the wrong answer. What happens is degeneration of anterior Greyhorn cells is going to be present in a case of a spinomuscular atrophy, right, which is a hereditary condition, and you're going to have upper limb and lower limb flaccid paralysis and loss of reflexes. Okay, the reason that's not the answer here is because we have a 14-year-old child, first of all, right? A hereditary condition would probably present very, very early on. And the second reason is that he had diarrhea 2 weeks ago. Okay, and so that's kind of suggesting a Guillain-Barré syndrome, right? Which is, just to recap very, very quickly, Guillain-Barré syndrome is a patient will have an infection a couple of weeks ago, and then they'll start to present with progressive ascending weakness. Okay, and it's an inflammatory syndrome where the immune system basically will start to target the myelin sheaths of the peripheral nerves. All right. And so, like we said, it's demyelination, right? So A or B is possible, but like we said, demyelination of peripheral nerves, and that would make the answer A. Okay. Now, just another thing to note, in the batch questions, this was put as C, but I could not find any resource that could explain why it was C. If any of you have like an idea, then that would be helpful. But I could find a good couple of resources that were suggesting A and Guillain-Barré syndrome. And again, like we said, the patient's old. They're probably not having a congenital problem. Otherwise, they'd present much younger, unless it was a degenerative disease. But like we said, spinal muscular atrophy would be hereditary, so it presents much, much younger, and it's not as slowly progressing. And the other giveaway is the diarrhea, which suggests some sort of reactive disease. Okay. Is that all clear? Mm-hmm. Also, like kind of related fun fact. Actually, who gave you guys this lecture? Was it Dr. Orban? Yeah. Did he happen to mention that he has Guillain-Barré? Well, I guess now you guys know that. Yeah, that was one of the things that he mentioned to us a couple of years back. But yeah, so basically, when you have infections, roughly what happened was he caught a GI infection when he was in his early residency from one of the cases that he was working on in pathology. And so because of that, eventually, what happened. What are they dreaming on? Okay, so the next case is the case of communicating hydrocephalus. CT scan reveals marked enlargement of the. Oh wait, is this the same case as the one before? Enlarged lateral and third and small fourth ventricle.
Yeah, that's the same.
Yeah, okay. It's the aqueductus sylvius. We have a patient that presents with construction apraxia. Which of the following is going to be damaged? Yeah, this one's a bit of a thinker. But basically, construction apraxia is where you give someone a drawing and they can't copy it, right? Which is one of the signs of, which is a presentation that commonly presents with Gerstmann syndrome. Let me just pull up the receipts. So here we have construction apraxia, like roughly. Okay, as you can see, the patient is really struggling to replicate drawings that they're presented to them. They aren't really able to draw a house. They aren't really able to draw buildings and stuff like that. And commonly, it will present with Gerstmann syndrome. Okay, now Gerstmann syndrome it will affect the parietal lobes. Okay, and so it's also the part of the brain that is associated with Wernicke's aphasia, and so the answer here is going to be B, the ventrolateral parietal cortex. Okay. Like as we said before, Wernicke's aphasia, parietal cortex, ventrolateral. Ventrolateral here basically describes the location, right? Going off of the word lateral, I think you can get the idea that it's going to be more towards the outside compared to, for example, something medial, which is going to be describing the sensory input. The break sounds so good right now. Is it possible to take a break right now for like 5 minutes? Amen?
Yes, of course, of course.
All right.
Let's take a break. Yeah.
Sure.
We'll be back at 12.
Okay. You guys can contemplate this question for a while. I'm so glad the people watching the recording got to see the seal. Anyhow, let's just quickly move on, try to pick up the pace a little bit, if that's okay, so we have time for you guys to have soul. Okay, a patient presents with visual agnosia. Which of the following is damaged? All right, so very quickly, agnosia is an inability to understand things, right? And so, since we have visual agnosia, where do you guys think it's going to be What do you guys think the damage is going to be? Okay, so quite briefly, visual agnosia means that you're having a difficulty processing what you're seeing, right? Which is going to be handled by the temporal lobe. And so it's going to be the medioventral temporal cortex. And so the answer is C in this case. All right. And then we have, which of the following plays a role in organizing behavior and in working memory? Okay. Now you might actually know the answer from psychiatry for this one. Okay, so basically the part of the brain that is going to be responsible for organizing, working memory, planning, and handling, all of that is going to be the dorsolateral prefrontal cortex, which is in the frontal lobe. Okay, so the answer in this case is going to be C. Next answer, which of the following plays a role in recognition of sensory stimuli and storage of semantic memory? Okay, so I'm going to be honest, a bit of a giveaway answer is in the like 2 questions ago. With the patient with visual agnosia. So they had difficult recognizing sensory stimuli and pulling out from their semantic memory. And so in this case, the answer is going to be B, the temporal lobe. Okay. The limbic cortex, right, or specifically the hippocampus, does handle memory. However, in that case, it's only going to handle short-term memory, right? And it's going to handle emotions instead. Okay, is that clear? Hopefully. Then we move on. So we have a patient that's not able to feel fear. Big giveaway, right? Which of the following parts of the brain is going to be damaged? Right, so the hippocampus handles memory, so it's not really related to fear. The thalamus, as we all know, is the big boss of the brain. It's going to be where all of the sensory stimuli gather and are transferred. The amygdala is the part of the brain that handles emotions, all right? So we have a clinical scenario where a patient is unable to learn new tricks, right? Kind of like saying can't teach an old dog new tricks. I guess the patient was an old dog. Which of the following is going to be damaged? Okay, so it's not going to be the amygdala, which handles fear, or the thalamus. It's going to be the hippocampus, which is responsible for storing memory. All right, and that is how a person would learn new tricks. Okay, so for the next part, I'm going to sort of pick up the pace a little bit, right? If I'm going too fast, let me know. These questions are a bit longer. They're a bit like more case oriented. And because like I said, the neuro exam does tend to be a little bit on the longer side. And so it can be very exhausting to go through. All right, so deep breath, bismillah, let's go. So we have a 60-year-old man. Okay, so we have a 65-year-old man, and they're brought to the emergency department by ambulance because of a severe headache, nausea, and vomiting that began 2 hours ago. Okay, so 2 weeks ago he had bacterial meningitis, and he's disoriented. All right, his pulse is 55 beats per minute, his respirations are 10 per minute, and his blood pressure is 155. So he has a high blood pressure, low pulse, and low respirations. Thromboscopy shows bilateral swelling of the optic discs. An MRI of the brain shows ventriculomegaly and scarring of a structure that is derived from the diencephalon. Okay. The patient's symptoms are most likely to be caused by obstruction of which of the following parts of the ventricular canal? Okay. Is it central canal, cerebral aqueduct, lateral apparature, lateral ventricle, third ventricle, or the fourth ventricle? Okay. So the main thing to focus on is the fact that the MRI of the brain has ventriculomegaly, right? And we have the diencephalon. Okay. So the key thing to think of here is to be able to identify which of these comes from the diencephalon and are going to cause a ventriculomegaly. And the answer here is the third ventricle, right? As we can see over here. So the third ventricle is the only one that's from the diencephalon out of these options. And it's one of the secondary brain vesicles. The lateral ventricles are from the telencephalon and the cerebral aqueduct from the mesencephalon, while the fourth ventricle is from the metencephalon myencephalon, right? So we have a 54-year-old man with hypertension and congenital blindness. He came to a physician because he's unable to recognize objects by touch with his right hand. Okay. Symptoms started about 2 hours ago. When given a house key, he can feel the object, but he can't tell what it is. Okay. Which of the following is going to be the cause of the lesion? So, the frontal gyrus and the temporal gyrus are both pretty unlikely, since in this case we're talking about being able to recognize objects via touch, okay, which is going to be handled by the parietal lobe, right? The precentral gyrus is also motor, so that's unlikely. And the only one out of these which is going to be handling like sensory recognition is the parietal lobe, right? Which is why the answer is going to be contralateral superior parietal lobe. Okay. The cingulate nucleus, well, it's ipsilateral, so you can immediately rule it out because we're expecting something contralaterally to the side that's affected. And the cingulate gyrus is also part of Papez circuit, which handles emotions. So it's part of the limbic system. It's not really involved in sensory stimuli. All right, and so that's why the answer is C. A 34-year-old woman comes to a physician because of 6 weeks of depressed mood, loss of interest, and difficulty sleeping. She has also had 4.5 kilograms of weight loss during these 6 weeks, and she has suicidal ideation, difficulty concentrating. There's no evidence of suicidal ideation. Laboratory studies show that TSH is normal, so thyroid stimulating hormone is normal. The physician describes escitalopram, okay, which is an SSRI. The drug targets a neurotransmitter that's produced in which of the following brain structures? Right, so escitalopram is an SSRI, and so it produces serotonin. Right, remember SSRIs are selective serotonin reuptake inhibitors. And where is serotonin produced? If anyone would like to take a quick guess. Okay, so the caudate nucleus is part of the basal ganglia. And so it's not really going to be related to this case at all. Like immediately you can eliminate that. Similarly, The nucleus accumbens and the basal nucleus are also not exactly related. The locus ceruleus is related to stress, but it's going to be producing cortisol. Okay, the substantia nigra produces dopamine, and it's part of the motor circuitry as well. That would leave the raphe nucleus, which is the one that produces serotonin. All right. Hopefully that's clear. Again, if I'm going too fast, please let me know and I'll take it down a notch. Right, and that's why the answer here is the raphe nucleus. The way I like to remember this is, I don't know if you guys know Rafi Mutawwa, who's a fourth year. I wonder if I can find a picture of him online. Yeah. So this guy, one of the things about him is that anytime you meet him, he's going to try and make you smile as a general rule, right? And so I associate smiling with happiness with serotonin, and so the raphe nucleus is associated with serotonin. Okay, that's just like a small mnemonic I like to use for that. Okay. So we have the next case is a 61-year-old man that's brought to the emergency department because of weakness of the right arm and leg that began 3 hours ago. He hasn't noticed any weakness when he went to bed the night before. And he has hypertension and hypercholesterolemia, and he has medications for the hypertension and the hypercholesterolemia. So he's taking an antihypertensive and he's taking a statin, right? Thiazide diuretic. He's alert and oriented, and his temperature is 36.7, his pulse is 91, and his blood pressure is 132. Okay? So generally, like, vital signs are generally stable. All right? Examination shows drooping on the right side of the face, when muscle strength is decreased on the right upper and lower extremities, but deep tendon reflexes are +4, right? So this patient has hyperreflexia. Sensation is intact, so no sensory deficits. His speech is normal in both rate and rhythm. The remainder of examination shows no abnormalities. Where do you think the lesion is? Okay, so because this patient has a general sensation, like a loss of general sensation, that's going to be as a result of a loss of the posterior limb of the left internal capsule. That's why it's right-sided. Okay. The base of the left pons, you'd expect like sort of different damage to the left pons is going to result in drooping of the ipsilateral side of the face, which is why that's not the case here. Similarly with the lateral medulla, it's going to have a different presentation for the drooping of the side of the face. Yeah, so sensation is intact, but the so let me just diagramficate. Okay. Oh wait, I said it wasn't intact? Or... Yeah, sensation is intact. I'm sorry, I might have misspoken. But the point is because it's a pure motor on, like, completely on one side of the body, that sort of is a giveaway that it's going to be a posterior limb of the left internal capsule, right? Because it's on the right side, so it's on the left internal capsule. All right. So that's generally just like, it's a bit of a red flag highlight, if that makes sense. I'm not sure. Is there anything that might need further clarification? I'd be more than happy to. Okay, so this is going to be the next case. And this is sort of like the previous case, but a little bit backwards. All right. So we have a patient. They present with a suspected stroke. They have history of hypertension, and the patient's wife reports he's right-handed. We have a CT scan with an acute infarction, and a photograph of the brain is shown. The area that is affected is indicated here. Right, so this is what, guys? Okay, so this is going to be the posterior limb of the internal capsule over here. And as we saw in the previous case, it's going to be responsible for a motor on the contralateral side, right? And as you can see here from the labels that are at the bottom, this is on the left side of the brain. Okay. So yeah, as some of you have guessed, the patient's going to present, which is what the question is, what's the most likely presentation? It's the most likely symptom you're going to find. It's going to be weakness of the right leg. Okay, you're not going to expect hemi-neglect since there's no really affect on the parietal lobe. This is the posterior limb of the internal capsule. It's not Wernicke's area. There's not going to be any hemibilismus on the left side. Okay. Or paralysis of the left face. The reason there's no paralysis on the left face is because it's going to be contralateral, not ipsilateral. You're also not going to get any damage to sensation or any effect to the visual field. Like we saw in one of the previous questions, the visual field passes sort of over the internal capsule and doesn't go through it. And so yeah, that's going to be the answer to that. So we have, for the next case, we have a 72-year-old woman, and she is brought to the emergency department with sudden onset of neck pain, nausea, vomiting, and difficulty walking. she can't sit upright without propping herself up on her hand. She has history of hypertension, type 2 diabetes, and atrial fibrillation. She does not smoke. She does not smoke. She drinks a glass of wine every other evening. And would we see paralysis of the face if the NEU was involved? So, if you have a damage to the NEU, you'd expect to see some sort of injury to the cranial nerves, right? So yeah, you might see some sort of paralysis of the face if the NEU is affected. Does that make sense? Because it's going to carry the cranial nerve motor neurons. Okay. So she can't sit upright without propping herself up on her hands. She has a history of hypertension, type 2 diabetes, and atrial fibrillation. She drinks a glass of wine. Her current medications include enalapril, thiazide, metformin, and warfarin. All right, lovely. So diabetes and hypertension medications, as well as warfarin for the AFib. She's 162 and weighs 68. She's mildly overweight. Her temperature is 37 degrees. Her pulse is 103. Her blood pressure is very high. Neurologic examination shows downbeat nystagmus, neck stiffness, head bobbing, and a broad-based gait. She's unable to perform a balance test or perform a Romberg test. Which of the following is the most likely cause of the lesion? Like, which of the following lesions is the most likely cause of these symptoms? Okay, so we're seeing a lot of struggles with the medial parts of the body. So she can't sit upright without propping herself up. She's unable to perform a Romberg test. She's unable to perform a balance test. She has a very broad-based gait, which again is more indicating of a medial lesion. And she has a neck stiffness, and head bobbing, right? So all of this is sort of telling you that it's going to be in the cerebellum, and it's going to be medially in the cerebellum, right? And so that way, we know it's not going to be the cerebellar hemisphere, right? And we also know it's not going to be the frontal lobe, since that doesn't affect the Romberg test at all, or the pyramidal tract, or the posterior spinal cord. That leaves the cerebellar vermis and the flocculonodular lobe. Okay. Now the reason it's not the flocculonodular lobe is because we have all of these other symptoms that aren't strictly related to balance. Does that make sense? So the flocculonodular lobe is much more strictly related to the vestibules and communicating with the vestibules, right? And so because of that, you wouldn't really see like an inability to sit upright with a flocculonodular lesion and stuff like that. And so in this case, the answer is going to be cerebellar vermis, the cerebellar vermis, C. Okay. So 2 weeks after admission to the ICU, a 54-year-old man regains consciousness. At the time of admission, a CT scan showed evidence of an intraparenchymal hemorrhage from a ruptured aneurysm. The patient is mechanically ventilated. A neurologic exam shows quadriplegia, exaggerated deep tendon reflexes, and the Babinski sign. He responds to questions by blinking, but he can't move his neck, he can't move his tongue, or any of his other facial movements. All right? They did a doll's eye test, and it shows restricted horizontal movement, but preserved vertical movement. And on a mental status exam, he's alert and comprehends the physician's questions. This patient's condition is most likely caused by bleeding in a region supplied by which of the following arteries? Okay? So before we answer the question, what do you guys think is the most likely condition that this patient has? Actually, wait, I said I would speed up a bit. Okay. So this patient has quadriplegia. Okay, he has hyperreflexia and a positive Babinski sign, right? This tells you that he has upper motor neuron deficits. Okay. And also because we have damage to the face, because we have loss of facial movement, and the only thing that's preserved is blinking and vertical eye movement. Okay, so from that you can sort of infer that what the patient has is locked-in syndrome. Okay, and locked-in syndrome affects the pons, right? And so which artery supplies the pons, which is basically the question that they're asking here? That's going to be the basilar artery. All right.
What was the answer to the previous question?
The one before? Okay, so the answer to the one before is the cerebellar vermis. We had a patient that couldn't sit upright without propping herself, history of hypertension, diabetes, and on medications for those. She's slightly overweight and hypertensive. She's very hypertensive. She has nystagmus, stiffness, head bobbing, broad-based gait, and a positive Romberg test. And so the lesions affecting the cerebellar vermis, since it was more medial. Hopefully that's clear. For this one,
Since it was what?
Since all of her symptoms are related to loss of functions in the medial part of the body, so like central, so she has a broad-based gait, so.
Would we call this truncal ataxia?
Yeah.
Okay. So can we call this also posterior vermis syndrome? Or no? Actually, we said earlier posterior is usually in children because of medulloblastoma. So this would be anterior?
This should be more anterior.
Yeah. Okay. Thank you.
Again, also because she drinks, and anterior vermis presents more in alcoholics.
Yeah, true.
Okay, so for this one, the answer is going to be basal artery, like we said. The patient has basically all of the classic signs of locked-in syndrome. He can't move anything at all except blinking and vertical eye movement. Okay, and so it's a lesion that affects the pons and the bleeding. Okay, that's going to be where the bleeding is, and the pons is supplied by the basal artery. Okay. We have the next case is a 48-year-old male that has a stroke, and there's damage to the superior cerebellar peduncles. Okay, and so there's loss of output from the cerebellum to the brainstem and the cortex. Which of these symptoms are they most likely to have? Right. So this case is fairly straightforward. Right. The cerebellum is mostly related to coordinating movement, And so you're not really going to expect anything to do with learning and memory, anything to do with hearing, vision, aphasia, or agnosia, which leaves D as the answer. Okay. Now, one test for cerebellar dysfunction is to ask the patient to rapidly move his hands from pronated to supinated back and forth multiple times. Normal patients should be able to do this pretty easily and have smooth and controlled motions. If you can't complete this test, what is it called? Okay, so the answer here is dysdiadochokinesia. Right, anosmia is an inability to smell. Agnosia is an inability to recognize objects. Aphasia, an inability to speak. And rapid alternating movement disorder is kind of exactly what it suggests, really. And so yeah, dysdiadochokinesia is the symptom of being able to pass the test, and it indicates cerebellar function. So a lesion of the cerebellar cortex would lead to a loss at the deep cerebellar nuclei of So for this question, you can almost immediately eliminate answer A, as well as D and F. Okay, seeing as Purkinje cells are inhibitory, climbing fibers are excitatory, and so are mossy fibers. And so that leaves B, C, and E. Of these, Purkinje fibers are the ones that will sit in the cortex and then pass on signals to the deep cerebellar nuclei. And so in this case, B is going to be the answer. All right. Whereas the mossy fibers and the excitatory are going to come from outside of the cerebellum, which is why they won't be affected by the lesion. This is a very simple histology question. What are these cells that are dark staining? And the answer is Purkinje. Okay. Which of the following telencephalic structures is part of the striatum and the lenticular nuclei? Okay, so the striatum is going to be your caudate and your putamen, whereas the lenticular nuclei is the putamen and the globus pallidus. And so the one structure that's present in both is the putamen. Okay, so for the next question, we have which of the following, let's repeat it again. A 76-year-old male patient with hypertension has a thrombus that developed in his right posterior cerebral artery, and it disrupts the blood flow to his right occipital cortex. What's going to be the sensory deficit? So he's definitely not going to lose anything to do with his hearing, and so we can eliminate those since we're talking about the occipital cortex. He's not going to lose anything. He's not going to have aphasia, and he's not going to lose his long-term memory at all. That leaves his vision. Since we have a loss of the right occipital cortex, that's going to affect the contralateral side, and so the answer is D. Okay. We have an 83-year-old male, suffers from a stroke that produces a left-sided sensory deficit, including a loss of general sensation, pain, and temperature from the body and face. There are no motor or cerebral deficits. And so which of the following regions indicates the site of this lesion? Do you want me to repeat this question here? Or the one before it? Okay. So which of the following structures is part of both the striatum and the lenticular nuclei? So here we're talking about the basal ganglia, right? And so the striatum is made up of two structures, the caudate nucleus and the putamen, while the lenticular nuclei is made up of the putamen and the globus pallidus, right? And so which structure is present in both? That's going to be the putamen. I hope that made sense. Okay, happy to help. Right, so we have an 83-year-old male. They have left-sided sensory deficits, including a loss of general sensation, a pain and temperature from the body and face. There's no motor or cerebellar deficits. Which of the following regions indicates the site of the lesion? This diagram is a little bit bad, so just to help you guys out, this one's A. I think you can see that. This one here is B, so B is red, C is yellow, D is blue, and E is whatever that color is. Okay, so in this case, since we have sensory deficits and a complete loss of general sensation, we're looking for a structure that's related to that, right? And so B, D, and E are all going to present with motor deficits, as well as A, which is the caudate. They're all going to present with some form of motor or cognitive deficits, right? C here is the thalamus, and that's where all of the sensory tracts are going to converge before they start to spread out in the cortex. All right? And so the answer here is C. Okay, which of the following demarcated regions indicates the location of the globus pallidus? So A, like we said before, this is the caudate, B is the putamen, and then these together, so B and D together, are the lenticulate bodies. Yeah, they are the ventricular bodies together, and so the answer here is D. Okay. The following statements concern the intracerebellar nuclei. I'm not really sure why the nuclei is worried, like why it's concerned, but we'll worry about that later. So first of all, the nuclei are found within the superficial layers of the white matter. This is false. The nuclei are actually deep within the white matter. They're not in the superficial layers. Okay, so this is intracerebellar nuclei. B, the nuclei are located in the walls of the fourth ventricle. They are not. They are located posteriorly to the roof of the fourth ventricle. All right. As for being unipolar neurons, they aren't. They're multipolar. Just to make a small illustration. So they're kind of star-shaped, which would tell you that they're multipolar, compared to peripheral sensory neurons, which are unipolar or pseudo-unipolar. D, the axons of the nuclei form the main cerebellar outflow. This is the correct answer here. And finally, E, from medial to lateral, the nuclei are named as follows: dentate, emboliform, globose, and fastigial. Now this one's a little bit tricky here because what they did is they actually swapped medial and lateral, right, to kind of throw you off with the mnemonic. It actually should be from lateral to medial. Okay, so as you go in through the cerebellum, you're going to see the dentate, emboliform, globose, and fastigial. And you have the mnemonic of don't eat greasy foods. So as you go in, don't eat greasy foods. That's the answer there. Okay. So the following statements concern the functions of the cerebellum. The cerebellum influences the actions of muscle tendons. This one's a little bit tricky, but the cerebellum doesn't influence tendons, it influences the muscles themselves. B, cerebellum controls voluntary movement by coordinating the force and extent of contraction. This one here is the right answer. C, the cerebellum inhibits contraction of antagonistic muscles. Oh wait, sorry. C, the cerebellum stimulates the contraction of antagonistic muscles. This is also wrong because it inhibits the contraction, it doesn't stimulate it. D, the cerebellum directly influences skeletal muscle activity without the assistance. Okay, this one's a little bit of a giveaway, but it's also wrong since the cerebellum has the assistance of the cerebral cortex and it does things indirectly. Okay, and finally E, the cerebellum coordinates peristaltic waves to intestinal muscle. This is also false since the intestinal muscle is smooth muscle and it's coordinated completely separately. The cerebellum is only concerned with skeletal muscle. Okay, so it doesn't have any effect on the intestines. And so the answer for this one is B. Okay, the following statements concern the cerebellum. The cerebellar cortex has a different microscopic structure in different individuals. This answer would be kind of concerning if it was correct, since having different brain structures between different individuals would be a lot of problems for medicine. But it is incorrect. The axons of the Purkinje cells exert an inhibitory influence on neurons of the deep cerebellar nuclei. This is actually true, but I'm not sure why for this particular question in the book. They were saying that the Purkinje cells exert a stimulatory influence, which is very weird, but anyhow. So each cerebellar hemisphere principally influences movements on the opposite hand. This is also incorrect since the cerebellum works ipsilaterally, so it doesn't affect the opposite hand. D, the part of the cerebellum that lies in the midline, is called the flocculus. It is not, it is called the vermis. And finally, E, intention tremor as a sign of cerebellar disease. This is correct. So the answer here could be E, it could also be B. So in that case, we appeal it, but if it comes, the safer answer is E in this case. Okay, so the following statements concern the basal nuclei. Right, the amygdaloid nucleus is connected to the caudate nucleus. This one here is correct. I might as well try and show you an image. Okay, so as you can see here, you have the amygdaloid nucleus, or the amygdala that's over here, and then it's connected up to the caudate nucleus as part of Pepez's circuit. All right. Other than that, you can also. How many questions are left? I think it's roughly around 20. I'll try to speed up because I also need to finish soon. But inshallah, we should be done within the next 10 minutes. Okay? Again, if I'm going too quickly, let me know so I can slow down. Okay, so the lentiform nucleus, right, is completely divided by the external capsule into the globus pallidus and the putamen. This is incorrect. It's not divided by the external capsule. As for the claustrum, okay, does not form part of the basal nuclei. It does, is part of the basal nuclei. The corpus striatum isn't medial to the thalamus, it's lateral to the thalamus. And the function of the colostrum is completely unknown. Okay. So, the following statements concern the basal nuclear ganglia. The corpus striatum is made up of the caudate nucleus and the amygdaloid nucleus. This isn't true since it's made up of the lentiform nucleus, not the amygdaloid. B, the head of the caudate nucleus lies lateral to the internal capsule. It doesn't, it lies medial. C, the insula is not a part of the basal nuclei. The insula is a sort of, if you open the temporal lobe, like if you open the gap between the parietal and temporal lobe, that's where you'll find the insula. D, the tail of the caudate nucleus lies in the roof of the lateral ventricle. This is correct. Okay, and finally, E, the subthalamic nuclei are functionally closely related to the basal nuclei, but aren't considered and are considered to be a part of them. This is true. This is wrong because they aren't considered to be a part of the basal nuclei. The efferent fibers of the corpus striatum. Okay, so many of the efferent fibers descend directly from the motor nuclei of the cranial nerves. This is wrong because none of the efferent fibers from the corpus striatum do that. B, some of the striatopallidal fibers have GABA as the neurotransmitter. This is true. Okay, so this here is going to be the correct answer. All right. I'm going to move on just so we spend time. So we have a 10-year-old boy. They have a headache, early morning vomiting, staggering gait, adiadochokinesia or dysdiadochokinesia, a finger to nose sign, heel to shin sign, bilateral Babinski sign, choked disc, abducent palsy, scanning speech, which is I did not give my toys to my son for Christmas. What's the most likely diagnosis here? It's not going to be Brown-Séquard syndrome, which is where half of the spinal cord is affected, or olivopontocerebellar degeneration. What the answer is going to be is posterior vermis syndrome, right? All of these are indicating some sort of cerebellar damage, right? And since they're a child, the most likely cause is going to be posterior vermis syndrome, all right? Tabes dorsalis is more related to syphilis, and so you wouldn't really expect that. And yeah, so they don't have truncal ataxia, which is correct. The thing is, because they have cerebellar, because they have multiple cerebellar signs, you're expecting something to do with the cerebellum, right? And so you can rule out Brown-Séquard and Tabes dorsalis that way. Sturge-Weber syndrome is neurocutaneous, okay, and so you'd expect some sort of So you'd expect a neurocutaneous disorder, you'd expect it to affect the skin, and it should have an AV malformation in the telencephalon, which we don't see here. So that leaves B and C, olivopontocerebellar degeneration. Okay, it's an autosomal inherited syndrome, and it has gait ataxia, dysarthria, and as well as tension tremors and Parkinsonian signs. All right. And so we're not really seeing any Parkinsonian signs here, and so that's why the answer is C. Does that make sense? And so although we're not seeing the truncal ataxia per se, right? Oh no, wait. They do have a staggering gait, which is like a big red light for a cerebellar lesion, and we have multiple cerebellar signs. Okay, that aren't really indicating that they aren't really suggesting a hemispheric disease. Okay. So, which of these thalamic nuclei has a motor function? A very basic recall question. So, just to quickly answer it, it's the ventral lateral nucleus out of these. Okay. I wish I had the time, but I don't really think we're going to be able to go over each of the thalamic nuclei and what they do. Hopefully someone else is going to be able to do that for you guys, but for now we're just going to have to move on. So, which of the following thalamic nuclei do the cerebellar fibers project? So again, since we're talking about the thalamic nucleus that has a motor function, it's going to be the ventral lateral nucleus. What it does is it's going to take these cerebellar fibers and then project them onto the motor cortex. Okay. Next, we have the Papez circuit. All right, it's the circuit that involves the hippocampus, the mammillary bodies, thalamus, cingulate cortex, and the hippocampus. Okay, and then finally, we have a tract, and it connects the hippocampus with the mammillary bodies. Which of these is it? Yeah, it's the fornix, basically. That's what's going to connect the hippocampus to the mammillary bodies. All right. 25-year-old male prisoner of war is kept under long periods of intense stress. He has physiological and neurological problems. He will have blank neural growth in the amygdala, whilst he will have blank neural growth in the hippocampus. Okay, so since they're putting him under intense stress for a long period of time, he's going to have a increased growth in the amygdala. Okay, and so this is going to have more fear responses, and that's basically how you're going to get PTSD. Okay, comparatively, he's going to have decreased neural growth in the hippocampus, so he's going to have struggles with learning new things. Okay, and so the answer in this case is D. So a 35-year-old male patient has glioblastoma in this area of the brain. Which of the following deficits is he going to present with? Okay, so this image here is pointing to the area of the amygdala, right? And so the answer is going to be Kluver-Bucy syndrome, which is what happens when you have damage to the amygdala. Okay? So the next question is, which of the following statements concern the functions of the reticular formation? Okay, so the reticular formation does affect the reception of pain, so this one's wrong. As for B, it cannot influence all ascending pathways to the supraspinal levels. That's also wrong, since it influences all the pathways. C, by means of reticulobulbar and reticulospinal tracts, it can control parasympathetic and sympathetic outflows. This one's the correct answer, yeah. Okay, and because of that, it's going to affect biological rhythms and it's going to influence degree of wakefulness. Okay, which of the following statements concerns the functions of the limbic system? So fear and anger is wrong. Concerned with visual, it is concerned with visual experiences. That's the occipital lobe. The hippocampus is concerned with recent memory is the correct answer. Olfactory function, no. And activity of the endocrine is also no, since it does it indirectly through the hypothalamus. 40-year-old woman was referred to psychiatric clinic with signs of nymphomania. Which part of the brain is going to be the one that's affected here? In this patient, so since she has nymphomania, okay, it's going to be related to emotions. And so in this case, it's going to be the amygdala. All right. Like, by the way, just a quick hint, like a sort of giveaway hint. Anytime we're mentioning the psychiatric unit, the answer is probably going to be the amygdala, right? Since it's the one that's handling emotions. That's sort of a, what's nymphomania? So nymphomania is basically when the patient has a very, very high libido, a very high sex drive, that they have no ability to regulate or control, right? And so what you're going to see in these patients is they're going to be like pouncing on people, attacking people. They'll constantly be flirting with people and stuff like that. Okay? Not a very pleasant disease to have at all. So, which of the following best reflects the anatomical or functional properties of the central nucleus of the amygdala? Okay? Okay, so projected axons for the medial hypothalamus is wrong. Tertiary auditory and visual signals is also wrong. High concentrations of enkephalins, somatostatins, and dopamine is the answer. There's not really much to explain here. You're sort of just going to have to memorize this with kind of brute force. But one thing you can use to memorize is that since we have dopamine here, and dopamine is the reward chemical in the brain, it's kind of like hinting that C is the right answer. Okay? And so the amygdala has very, very high levels of enkephalins, somatostatin, and dopamine. Since these are sort of related to regulating emotions, that does make sense. All right? Okay, we have a boy that was bitten by a dog, later developed rabies, which wasn't treated. The infection affected and destroyed short-term memory functions and resulted in memory deficits. Which of the following groups of structures was most likely affected? So the hippocampal formation is sort of a given, right? Basically what they're looking for here is the Papez circuit, right? They want you to identify the Papez circuit, which is, and so in this case, the answer is going to be C, right? The hippocampal formation, mammillary body, anterior thalamic nucleus, and cingulate gyrus. All right? Which of the following is the area affected by this diagram? Okay, we saw a similar question above before, okay, where if you can see the structure here, then you're able to see the midbrain. That tells you that it's the hippocampus, right? That's basically how you identify it from the amygdala, if you're able to see the brainstem down here, the midbrain. Okay, and so that's why the answer is B. All right. 70-year-old male brought to the ER, experiencing headaches, nausea, dizziness. MRI revealed the presence of a brain tumor. He has a non-communicating hydrocephalus. Which of the following is the most likely location of the tumor? Okay, so he has non-communicating hydrocephalus. And he has dizziness, nausea, and MRI. So you're expecting something that's going to cause a block in the CSF tract, right? Cerebral arachnoid space. Yeah, the last one was B. Like we said, so since we're pointing at the structure and you can see the midbrain, that makes it the hippocampus, basically. So for this question, non-communicating hydrocephalus, so there's a block somewhere. Usually you'd expect it to be the aqueduct of Sylvius, but that's not an option here, so we're not going to go with that. The other case is usually the foramen of Monro, or the intraventricular foramen. And so in this case, the answer is C. Okay, it's not going to be the cerebral subarachnoid space, since that's going to present with communicating hydrocephalus instead. All right. And it's going to result in enlargement of the lateral ventricle for the previous question. For this one, a 67-year-old female was admitted to the hospital after she reported to their primary care physician that she has very painful headaches. Further examination has high intracranial pressure, and they did an MRI. So she has a developing tumor on the rostral aspect of the medial wall of the lateral ventricle. Okay? They basically want you to identify which one of these this is. And yeah, the answer is G in this case. Okay? We're talking about the lateral ventricle, which is in this area. And the only one that's really related to the medial wall at all is, out of these options, is G. Okay? Since it's the septum pellucidum, which forms the medial wall of the lateral ventricle. Okay. They have an automobile accident in a teenage boy, and they have a subarachnoid hemorrhage as a result. Which of the following CSF findings do you expect in this individual? Okay, this one isn't really anatomy. Yeah. But basically, you'd expect increased CSF pressure, right, since they're having bleeding, and you'd expect bloody CSF, high red blood cells, and protein, as well as decreased glucose. So the answer is A in this case. But basically, the two giveaways here is increased CSF and bloody appearance. An elderly male patient suffers from a stroke that blocks blood flow in the right anterior cerebral artery just after the anterior communicating branch. So we have the two anterior cerebral arteries, and then this is the sulcal volus. We have a blockage here. The patient would lose blood supply to it's not going to be the occipital lobe because that's the posterior side, or the temporal lobe, which is supplied by the middle cerebral artery. It's going to be the frontal lobe, and since it's the right anterior cerebral artery, it's going to be the right side of the frontal lobe. So the answer is E in this case. Okay, this is another hematoma question. I'm going to be honest, even without reading the case, you can sort of tell from the image, because you can see the classic banana shape that we talked about here. Okay, and so we have a subdural hematoma again. Okay. And again, it's on the right side. That's mainly just part of the CT because flipped. Okay. So we have a 25-year-old obese woman, complains of headaches for 4 months. She's obese, has bilateral papilledema, and her vision is deteriorating. Her opening CSF pressure is elevated, and other CSF findings are normal. CT and MRI scans are normal. These signs are due to impairment of CSF egress, which is like CSF absorption, okay? So she can't reabsorb CSF. Where's the obstruction? Okay, so in this case, you're not really expecting any like you're not really expecting a non-communicating hydrocephalus, since we have problems with CSF egress. So it's not really going to be B, C, D, or E. And in this case, the answer will be A, the arachnoid villi. Okay. Basic question, CSF production, what's the daily amount? It's 500. Okay. That really, I just memorized the number. Following statements are about the tentorium cerebelli. Okay, so the tentorium cerebelli is the meningeal layer from the dura mater that of the dura mater. Let me just pull up a picture very quickly. So here we have the fossa cerebri, which is the one that separates the two sides. Then we have the tentorium cerebelli, which separates the. Then we have the tentorium cerebelli, which separates the cerebrum from the cerebellum. All right. Okay, so free border attached anteriorly to the posterior clin. Okay, this is a very random bunch of words, but it's attached anteriorly to the anterior clinoid process of the sphenoid bone. I don't really worry too much about that. It is formed from the meningeal layer of the dura mater. This here is the correct answer. It doesn't. It separates from the cerebellum from the cerebrum, so not from the temporal lobes. The sigmoid sinus lies within. It doesn't. The anterior edge of the tentorium cerebelli is not the occipital venous sinus, it's the tentorial notch. Okay, which of the following structures limits the rotary movements? Okay, now we saw it in the diagram before. It's not the tentorium cerebelli or the diaphragm cello, it's the false cerebri. Okay, so the structure that limits rotation movements is the false cerebri in this case. The following statements concern the ventricular system. Cerebral aqueduct connects the third and fourth ventricle. I mean, yeah, it's not really. Yeah, it's not related to the sigmoid sinus at all. The cerebral aqueduct connects the third and fourth ventricle together. This is the correct answer. The two lateral ventricles don't communicate directly. The foramen of Monro connects them to the third ventricle. Okay. The following statements concern the CSF. And the fourth ventricle. Okay. Produced mainly by the choroid plexus of the cerebral aqueduct. This isn't true. The choroid plexus is way before the cerebral aqueduct. It leaves the midbrain through the interventricular foramina. This is the correct answer. Okay. The following important nuclei lie beneath the floor of the fourth ventricle. Why not E? Okay. Sorry, I am a little bit tired. Okay, I'll get back to this one. I'm a little bit tired. I'm struggling to see the screen, if I'm going to be honest. But for the next question, which of the following important nuclei lie beneath the floor of the fourth ventricle? So the oculomotor nucleus is in the midbrain, and so it's not going to be beneath the floor of the fourth ventricle. Similarly with the trochlear nucleus, the trigeminal and olfactory nuclei are within the pons. The trigeminal nucleus is within the pons. The olfactory nucleus is above the brainstem, so it's not associated with the fourth ventricle. The answer here is D for this one. Okay. The following statements concern the meninges of the brain. Both layers of the dura mater are continuous through the foramen magnum. Okay. Eamon, I don't think there's one question left. Actually, no, let's just finish this one. Okay, so for the meninges of the brain, both layers of the dura mater covering the brain are continuous through the foramen magnum, with the dura covering the spinal cord. This is wrong because only the meningeal layer of the dura is continuous. The periosteal layer, it's continuous with the periosteum outside of the skull, okay, not the spinal cord. As for B, the periosteal layer of the dura mater is not continuous with the suture ligaments of the skull. Again, it is continuous with the suture layers. That's how you have epidural hematomas that respect the suture lines. C, as each cranial nerve passes through a foramen in the skull, it's surrounded by a tubular sheath of arachnoid mater only. It's not, it's surrounded by pia, arachnoid, and dura mater, so all three. D, cranial venous sinuses run between the meningeal and endosteal layers of the dura mater. This is the right answer. And finally, E, the meninges extend anteriorly through the optic canal and fuse with the periosteum of the orbital cavity. Which sinus drains the superior surface of the cerebellum? The answer here is the straight sinus. Okay. Just to go back to the CSF question. Yeah, so the way it escapes to the subarachnoid space is through the foramen of Lashka and Majindi. Each is laterally. I'm just trying to.
Yeah, I think for Majindi it would, or was that for Lushka? For one of them it would go up around the brain and then the other would go down to the spinal cord.
Yeah.
In that case, I think Majindi for the spinal cord and Lushka up towards the brain.
Mm-hmm. Sorry, I'm blanking out a bit. Okay, so for this one, I'm going to check later, and I'll send like a more detailed answer to Ayman once I'm awake, inshallah. Is that okay with you guys?
Yeah, no problem.
All right. Thank you guys very much for attending. This is a QR code from GND if you want to scan and send feedback. Thank you guys so much for coming. Best of luck on your exam. Inshallah, you guys will do amazing.
Thank you so much.
Let me know if you have, like, I don't know if Ayman